a consultant gastroenterologist at UCL and a consultant in advanced upper GI endoscopy with EUS and ERCP. Gavin his research background and academic interests are in teaching and training in EUS and ERCP and standard setting. And Gavin is talking to us today about putting the P into ERCP, which as an ERCPist myself still fills me with terror. So Gavin, look forward to hearing what you're going to say today.
Yeah, thanks very much, gentlemen, and good morning to everyone wherever you might be around the place. Shame I can't be in Sheffield with you chaps, but maybe next year. So as I've been introduced, my interest is in ERCP and EUS, and my job is to put the P back into ERCP, which is a fascinating title and great to be part of this program. Just next slide. Okay, so what I'm going to cover in the next 15 minutes or so is what I would sort of consider with me and my colleagues as part of the case selection and workup before we embark on any therapy for these guys. I know there's lots of fellows in the audience. They're probably no strangers to accidentally cannulating the pancreatic duct, but actually with a bit of know-how, this can be a selective cannulation of the pancreatic orifice. So I'm going to run through that for a couple of slides. And then I'm going to go through the indications for pancreatic access, so stones, strictures, pseudocysts, and just one slide on collections following a pancreatic resection. So this is how we sort of do things at University College Hospital. We receive a referral from far and wide. Pretty much all of those, in the context of intervention for chronic pancreatitis, we would bring into our benign MDT or our complex benign MDT, so not part of a cancer meeting. And we then ensure that we've reviewed all of the up-to-date imaging. We look at the referral letter for what the details may be, and then we put a hypothetical plan together as to the potential interventions, be it surgical, be it medical, or be it an ERCP intervention. But what's very important then is that we catch up with the patients, which is now routinely on the telephone, of course, and just sort of verify that they're symptomatic. And that's really crucial because you don't want to be intervening with any of these patients if they are not symptomatic. We still receive lots of referrals where people are concerned about an MRCP or a CT, but in fact, in benign disease, if they're asymptomatic, you probably need to do very little. Okay, so the consultation is important. Furthermore, if we're about to put them through an invasive ERCP with risks, they need to be pre-consented very carefully. So that's part of things. And then we get them up for the intervention following that. So what does our workup consist of? We review the latest imaging. CT is, of course, very useful, contrast and pre-contrast, to work out if they have calculi. The vast majority of calculi will be radio opaque, although early calculi may not be. An MRCP is always additive, of course, in that we tease out the ductal anatomy. We always have a very considered look as to whether there is cancer. Of course, a new stricture, you need to be very, very careful about whether we are missing a small neoplasm and a very low threshold for a diagnostic EUS in some of these patients. And then we work out whether the intervention is likely to be favorable. So what patients do better, either with surgical approaches or ERCP approaches. Short duration of symptoms, less severe pain, and we've all heard the old additive that if a patient's chronically on opioids, the chance of success is much more limited. Whether the disease, either strictures or stones, is limited to the head, and whether the patient has managed to stop drinking and stop smoking. So that's our workup, that's what goes through our head. And I know Christopher Briggs is talking on the role of surgery in chronic pancreatitis later, but these were the two trials that really we thought did it for ERCP and put it on the shelf. Trials from 2003 and 2007 coming down on the side of surgery, but both of these have subsequently been criticised. I won't go into the details of that, but largely the DITE study did not include ESWL, which is extracorporeal shockwave lithotripsy. There was no repeat endoscopy. There was no multiple stenting, no attempts to remodel strictures. And then in the Cahan study in 2007, these patients really were very, very advanced with chronic pancreatitis, where ERCP is probably more doomed to failure, and they were also opioid dependent. So I have to say in 2021, if there are favourable features then I think it's reasonable to try ERCP first, and we'll probably have a bit more debate about that with Christopher later on, I very much hope. So once you've decided to go for pancreatic endotherapy, what are the tips to getting in? Again, our fellows are no strangers to this in their early days, but you want to have a relatively short scope position. Are you seeing my pointer here? You want to have a perpendicular approach, as shown here on the right, to try and aim perpendicularly. The pancreatic duct runs away at sort of 90 degrees from the duodenal wall. Before you do anything, have a real close inspection of the orifice. You might actually, with the nice high resolution scopes we have these days, actually see the pancreatic orifice much more clearly. And that's particularly important if the patient has had a prior biliary sphincterotomy, which can in fact make pancreatic access quite difficult if they've had a biliary sphincterotomy. I would tend to use one of the more gentle 025 wires, increasingly using the angle tip wire, which is for reasons I'll come to in a moment. Aim perpendicularly. You're aiming at the floor of the orifice below the septum, as depicted in this bottom left image. And given that you may have a tortuous common channel, given that you're about to cannulate the pancreas and probably stent it anyway, I'm not so concerned about using contrast fairly early on in cannulating the pancreas, unlike if I was trying to access the bile duct where you're trying to avoid contrast. It's often very necessary, particularly in complex pancreatic disease, to tease a bit of contrast in to show you the way. The reason I quite like an angle tip wire is you get an early, what I call a J on the wire. And if you see this red line here depicting the wire, you see how it turns into a J maneuver very early. You can then push on the elbow of that wire. And what that means is that the wire tends to stay in the main pancreatic duct and avoid going into side branches. So that's a little tip for you. A single slide on pancreatic sphincterotomy. I think in most cases of pancreatic endotherapy, there is almost always an indication to improve your access and to maintain access and undertake a pancreatic sphincterotomy. An exception to that possibly is in a post-surgical case where a single stent for a short period of time may be sufficient. But a low threshold to undertake a pancreatic sphincterotomy, and the way we would do that is use a standard sphincterotome. One used to talk of pure cut current for the cut. I think that's probably no longer necessary with the modern systems. We're cutting in a 1 or 2 o'clock direction as depicted on the right-hand side for a distance of about 5-10 millimeters. But if you've done plenty of biliary sphincterotomies, there is no mystery to undertaking a pancreatic sphincterotomy. So let's talk about the particular indications, starting with stones. We all know these are a huge problem. A rule of thumb is that you've probably got a 50% chance of having calculi at 5 years and almost 100% after 15 years. And the predilection for stones would be males, smokers, and the heavy drinkers, more than 80 grams of alcohol per day. And the ESG guidelines, which are really very useful if you've not seen them, they're updated in 2019, talk about for stones in the head and body, then ERCP is fine if they're very small and in the main duct. But by small, we mean less than 5 millimeters. If you've got a stone more than 5 millimeters, even though that sounds piddling, you might struggle to retrieve that endoscopically on its own. And obviously, to undertake ESWL, you need a radio-opaque stone. But they actually advocate ESWL for any stone of more than 5 millimeters, which is interesting because we've never had great success with ESWL. You can probably predict that your ERCP will fail in terms of retrieving stones if the stone's bigger than 10 millimeters. Obviously, if there is a stricture downstream of the stone, as is very often the case, then you're probably going to fail to retrieve that stone unless you've already remodeled the stricture. If you've got multiple stones or diffuse disease, and also be very aware of the potential complications. So the tricks and tips that we use in the bile duct to retrieve stones generally don't apply in the pancreas in anything like the same way. Balloons you will struggle with because the stones often pop side branches. And if you undertake mechanical lithotripsy within the pancreas, be very, very careful. We've had certainly one episode of a mechanical lithotripta rupturing in the main pancreatic duct. And I'm sure all of our surgeons have received a call from a slightly sheepish endoscopist in the past to bail them out. The chance of having complications is 3 times that of the bile duct with the mechanical lithotripta. So be careful of baskets. Now, ESWL, we don't do much of it at UCLH. We probably ought to revisit it. If you look at the meta-analysis from 2016, it's profoundly successful. So complete clearance in 70%, partial clearance in 22%. And if you do manage to completely clear the duct with ESWL, you've got a 54% chance of having either absent pain or improved pain at 2 years. And most of these trials used an ERCP following ESWL, although in a reasonable RCT, albeit from 2007, it was shown that if the stone is small, you probably don't even need to follow it with an ERCP, which is always, I've always found slightly mystifying, but that's the data. And if you want some technical aspects of ESWL, which is an interesting read, again, the ESG guidelines are useful. However, we've pretty much moved to pancreatoscopy guided lithotripsy using the spyglass system from Boston. So ESG say this is a fine option if ESWL is unavailable, but given that our lithotripsy service and our urologists are based at a different building, we've never and a different hospital several blocks away, we've never particularly got on well with it. And since the advent of SPY, particularly the latest SPY, we've demonstrated significant success using EHL within the pancreas. So this was our case series of all our EHL cases in 2017. At that time, only 8 were within the pancreas, 7 of which were successful. But our data that's being written up currently is that we've got 25 cases of intraductal EHL within the pancreas with a 75% success rate. So this tends to be what we would go for. If you look at one of the more recent reviews of intraductal pancreatic EHL or laser, 383 patients, very heterogeneous, and I grant you, very hard to compare, but a reasonable clinical success with EHL. But I think we were all convinced if your Hounsfield unit is more than 1,000, there's a likelihood that laser is more effective. You deliver more energy with laser. It's also pretty forgiving. So we've not had any major adverse events. I think we've had a little bit of bleeding. The PEP rate is 7%, which is actually pretty incredible if you think what you're doing to the pancreas with perforations and bleeds, but no deaths and no mortality in this series. This is just a quick video. You might have to run that for me, guys. So there's the spyglass endoscopic view on the left, fluoroscopic view in the middle. Are you able to run that for me, team? And there's the EHL probe on the right. We'll move on, but that just shows how once you've got good access with a nice dilated duct, EHL is fairly straightforward to deliver. So moving on to pancreatic strictures, again, beware that there's not a small neoplasm there, a small neuroendocrine tumor, etc. The clues towards that being the case is that the odd patient who doesn't really have stigmata radiologically of chronic pancreatitis elsewhere in the gland. Low threshold to consider EUS in those circumstances. And the aims with pancreatic strictures is to decompress the duct, but also with a view to try to remodel the stricture. So a bit of evidence for what you might consider using for your stents. If you're using small stents, less than 8.5 French, there's an increased likelihood that they're going to present with pain due to stent dysfunction. And there's a little bit of evidence that the stents that come with multiple side holes to allow drainage from the side branches prevent blockage, which probably stands to reason and makes sense. And again, treating these strictures, severe PEP does seem to be rare. These pancreases that have seen a bit of action over the years tend to be quite forgiving for ERCP. So our practice at UCLH would be to try and get a stent up to 10 French and leave that in for up to a year and just change at any sign of dysfunction. It's not uncommon that you won't get a 10 French stent in immediately. You might need to start with a 7 or a couple of 7s and then bring them back at 6 weeks for an upstage of the size of that stent. And if that stricture proves refractory, there's probably better randomized evidence to use multiple plastic stents, as used to be the case in the bile duct, although there is emerging evidence on the use of self-expanding metal stents, and we would probably reserve these for refractory strictures in the head. Although there's a bit of concern if you actually do peruse the data that these tend to migrate, and a proximal migration is a problem, as well as developing de novo strictures due to their radial force. So I think SEMS is not quite so convincing as we would expect by now. A couple of single slide on pseudocysts. I think we're all very versed now at draining these transmurally, and I have to say the vast majority of ours at UCLH are drained transmurally. But if you actually think about how these pseudocysts are formed, understanding the ductal anatomy can really help you drain them appropriately. So an MRCP in the context of a pseudocyst really helps here. Does the pancreatic duct communicate? And if it doesn't, there's no point even considering transpapillary drainage. That's nice and easy. If you can see that there is a partial disruption of the main pancreatic duct, then there may be an endeavor to try and stent across to improve outcomes. But if that duct is disconnected, so you've got a tail of pancreas communicating with a pseudocyst, but no communication with the papilla, then what that also tells you is that you probably want to be aiming for much longer indwelling cystgastrostomy stents. And these are the circumstances where I may avoid a hot Axios lambs and go for plastic pigtails for a cystgastrostomy that can stay in for up to a year. We would probably reserve pseudocyst draining transpapillary for those that are small, those that might be quite distant from the upper GI tract for drainage. We do want to document communication with the main pancreatic duct, as I've argued, and those that are in the head. And a single slide on the use of pancreatic stents for post-surgical pancreatic resections. So we get a fair few of these up at the Royal Free annually. So this patient depicted here has had a left-sided pancreatectomy for a large mucinous cyst. There is obviously a surgical drain in there with amylase-rich fluid coming out, and these are brilliant at treating with a stent. And all you really need to do is get a plastic stent almost to the point of the leakage. The size of that stent will be determined based on the size of the pancreatic duct. Usually 7 is sufficient, in fact, in a small duct. So to conclude, I think ERCP does have an established role in the management of complications of both pancreatitis and pancreatic surgery, but case selection really is key here. You need to ensure there is a sound indication for intervention. I think case selection is so crucial that all of these should be discussed in a multidisciplinary meeting with our radiologists and our surgeons and our endoscopists. And happy to take any questions at that point. Thanks very much.
Thanks very much, Gavin. That was a great talk. I think we'd all sort of favour a benign MDT setting for all these patients, as they are very challenging in many ways. Can I just ask you about the difference in disease patterns between sort of Western European chronic pancreatitis and stone disease in the pancreas and those we've seen in perhaps India and Pakistan, where there's been very impressive data and presentations from centres like Hyderabad at our sort of national ERCP meetings, where they have a shockwave in one room, ERCP in the next room, and they're treating dozens of patients a day.
Yeah.
You know,
I think that explains the lack of success we've had with the SWL over the last 20 years. If you listen to Nagy Reddy talk about this, he's got a dedicated pancreatic lithotripsy machine. He's got a technician that's there, God knows how many hours per day, dialing up the energy to these stones. I think the energy these stones require is a different league from renal stones, kidney stones. So the technicians in the UK running these machines are just entirely unfamiliar with the pathology that we're dealing with. And I think that's probably informed the lack of success, certainly in our unit and probably across the UK, for running a successful ESWL service. I'd be delighted to hear from anyone with a different outcome to that in the UK if they're on the call. But I wouldn't say we've abandoned it, but we never really won with it. And I think now that we're getting reasonable success with SPY, that's the way we tend to go.
Way forward over the next 5 years in that actually SPY technology will just render the use of shockwave therapy pretty much moot.
Yeah, the ones we failed at, incidentally, are the ones with the huge Hounsfield units, over 1,000. You can probably predict DHL won't work. There's better data for the laser in those sorts of stones. To borrow the laser from our urologists, because it's in a different building, we haven't actually achieved this logistically. Apparently, we need to insure it for £2,000 for it to take a trip around NW1 into our units. We've never managed that, but there's at least a couple of patients that went to surgery who may have done very well with laser from a technical point of view. But there you go. Lasers are expensive. EHL is not, and EHL's fine for the bile duct. So that's what we've got.
One more. So time for one more question. It does say anonymous. It may well have been from Mr. Briggs, but it does say, what is your measure of success?
Well, that's exactly why one has to be very skeptical of the meta-analyses and these RCTs, because these patients are so heterogeneous, the conditions are so heterogeneous, the mechanisms of pain in pancreatology is poorly perceived. But yeah, it's going to be reducing analgesia, isn't it? Getting them off opioids or preventing them going onto opioids in the first place. But it's pain and quality of life measures. That's what we use.
Thanks. So that's great. Thank you very much. Thanks for that
Thank
talk.
you.
And I don't look forward to the flood of referrals that I might now get for doing this.
That's a good point.
Yeah.
Thanks.
All right, Gavin, have a great day, and thanks ever so much
Thanks, chaps.
today. Stay online, mate. Take care. Take care. Now I have the actual pleasure for introducing our next speaker, who's